Thank you so much for inviting me to be present for this. And I really want to thank you in advance for what we're going to talk about today. So my name is Melissa Teply. I practice in outpatient internal medicine and also in outpatient palliative care at UNMC Nebraska Medicine. So I'm largely based in the clinic, and this is a topic that comes up for me in both sides of that practice. What I want to talk about with you today is advanced care planning. And there are a fair number of people who haven't heard what that is. And for those of you who have heard of that, I tend to think that it can bring up some kind of scary emotions for people. It can be really overwhelming and daunting to talk about. And so I want to talk about what advanced care planning is, why it's important, and then to start getting into how you can try to think about communicating with your family and medical providers about this. In terms of that more nuts and bolts definition, advanced care planning is making decisions or making broad values and preferences known for a time when you might be so sick that you can't communicate those wishes to your family and your healthcare team. This can be helpful in two broad scenarios. One would be a life-threatening emergency. So if I walk out of this building and I get hit by a bus and I end up in the ICU, I can't talk to my healthcare team and I can't talk to my family. And so I need someone to speak on my behalf about how I would want to direct that care. The other time where this can come up is when we're facing issues around the end of life. Part of what can make advanced care planning difficult is because it is very complicated trying to navigate both of those types of scenarios. And so we are trying to simplify something that is really, really complicated. In terms of the more detailed steps of when I think through advanced care planning, part of it is understanding the medical care that we provide when people are critically ill or when people are facing decisions around the end of life. Things that we will try as medical interventions are what we call life-sustaining treatments. So that's things like CPR, breathing machines, dialysis, artificial nutrition, and deciding what types of treatment would be right for you or might not work as well as we would hope they would will change depending on your current health status and depending on your personal values and preferences. So part of it involves thinking about that. And then another step involves sharing that with the people that you love so that they understand what you would be thinking in that situation were it to come up. Then there's the whole process of actually putting that down on paper. And that is something that as we're going through this process, we're going to talk about how draining this can be to think about. And then you have to put it on paper, put it in writing, and then actually get it legally notarized or signed. In terms of why advanced care planning is so important, this is something that helps to match the care that you receive around the end of life with your wishes if you can't communicate with your healthcare team. The people who complete advanced directives are much more likely to receive care that is consistent with their wishes, and they're much more likely to be able to die at home. So in broad swaths, most people will say that if they're at the end of their life and they're dying, they don't want to die in a hospital. They want to be at home. The single most important reason that I think of when I think about my advanced directive is that this takes an enormous weight off of my loved ones in terms of them having to guess what to do in that situation. So practicing in medicine, working in the ICU, I can tell you that it is a tremendous struggle watching families as they feel like they have this enormous responsibility about the care that is given. And I can guarantee you that every medical team is doing the best that they can for every single patient that is in those situations. And even though we don't have a lot of control per se, families feel like they have control. We talk about this concept of pulling the plug on a loved one, and that's never the case. That's not what's happening, but it feels like that because we can't have that conversation with that person. In terms of some statistics and looking at survey data of people, the vast majority of people say this is important for us to talk about. But then you look at the percentages of people who say they actually have, and it drops down to maybe a third of people have had that conversation with their loved ones or multiple conversations about it over time. One of the reasons that they bring up is that they don't want to upset their loved ones. Get into that a little bit more. And then a fair amount of people say if someone brought this up to them, they would actually feel relief about it. In terms of how that interacts with their healthcare, the majority of patients say that they would want their doctor to talk about this if they're facing an end-of-life situation, but very few people report that they've actually had that conversation with their physician. Getting to the advanced directive, the vast majority of people say this is really important, we should put this in writing. But when it comes to walking the walk, people are not as likely to do it. So maybe about 35 to 40% of people have some portion of an advanced directive completed. And for those people, that's stayed consistent over time. So this is a national conversation that's been going on for the past 40 or 50 years, and we haven't really improved on that completion rate of advanced directives. There's a lot of different reasons why people may not have an advanced directive. What I would argue that I see from a practice perspective when I'm talking with my patients about this is that it's easy to put off. When you're feeling well, you say, well, I'm fine and I'm healthy, and so why do I need to worry about this right now? I will tell you that as people get sicker, and when I try to bring this up with them, it's one more thing. They don't want to think about it. They're already sick. They're going through multiple treatments. They're really overwhelmed with that. They're dealing with too much on their plate. And so trying to go through this is emotionally and logistically something that they don't want to have to deal with. I was going through those steps before. This takes time. You have to think about these issues. You have to talk about these issues with your loved ones. You have to put it down in writing. And then I'll get to more of the step-by-step process of completing the advanced directive, but it requires either a notary or a signature from two witnesses that are not your family members, not your power of attorney, and not part of your healthcare team. So that's an extra errand that you have to do on top of all the things that we're usually doing to try to get through our days. I have a fair number of people that will tell me, my family knows me well. They know exactly what to do for me in this situation. I trust them completely. And I absolutely respect that. I will just put out there that when there has been research done on this, when they put a patient and their decision maker, and they give them hypothetical scenarios about what that patient would want in that situation for their medical care, there is some discrepancy that the power of attorney had trouble making that decision, that it was mismatched with the person about 30% of the time. And so I don't mean to put that out there to scare people. I mean to highlight that I can't read people's minds. And as much as we love and trust and know each other, we can't read each other's minds. So the more that we're able to put that out there, the more helpful it will be in guiding people through these tough situations as they come up. In part, when I'm thinking about this as a healthcare provider, I tell my patients, this is just a just-in-case document. When I'm thinking about that emergency situation, the vast majority of people will not have critical emergent illness that arises as part of their care. So for that situation, it's really only going to go into effect if you're so sick that you can't communicate. It's something that helps the people that you love in terms of giving them some guidance about what they should be doing to do right by you. And it's kind of like an insurance policy, but that's really that emergency medical situation part. I have life insurance, I have health insurance, I have disability insurance, I have a will that is set up for my children if my husband and I were to die in a plane crash. But thinking about that advanced directive, I think is different. When we're thinking about the possibility of being near the end of life and not being able to communicate, at some point for all of us, that's not hypothetical, that's something that's going to be real. And I think that is a really, really heavy, difficult thing if we let ourselves think about that for a moment. If I am thinking about an advanced directive, I have to think about what are the medical interventions that I would be willing to go through for the chance of more time. I have to think about if I were to have a really bad cardiac arrest later today, what types of medical things would I be willing to go through? What would that mean if I had a really bad cardiac arrest or a bad heart attack when I'm 90 and I'm not moving around so well? What would it mean if I was diagnosed with something like ALS or Lou Gehrig's disease, where I know that all my muscles are going to get weak and I'm going to need a wheelchair, and at some point I'm not going to be able to talk to my loved ones? What does it mean if I have dementia and I'm moving around and I'm doing okay for some things, but I I'm not able to make decisions like I used to and communicate as clearly as I used to. How is that going to impact my care in the future? What if I'm in my 80s and I'm kind of doing okay and I've got some health problems, but I'm kind of having trouble living on my own? I don't even know. How do I navigate that? Like, I'm kind of doing okay, but maybe some of these medical interventions may not make as much sense for me. So I don't know. I don't even know where to start with thinking about that. To kind of open that up to a little bit more of a broad picture, I've given you multiple examples. I have to think about what are all the different ways that the end of my life could look like. And that seems really, really morbid. I have to think about what kinds of plans can I tell my family about now so that they have one less thing to worry about when I'm really, really sick. I have to think about how am I going to bring this up with my family without them feeling like this is super weird or that I'm upsetting them or that I'm giving up on life somehow. So how am I going to make this something that is important for my care going forward without making it too hard of a conversation? What if I make the wrong decision now for a future point in time? And that's really scary. So, so this is scary and this is depressing. And I'm going to ask you to sit here with me for another couple minutes because I think this is really important. And this is a really important part of why these conversations are so hard. When I think about what scares me the most when I am thinking about the end of my life, I immediately go to my kids. I've got 3 small kids. So if I were to die today, I have to think about what is their life going to look like growing up without me? What are all the things that I'm going to miss, that it just sucks that I'm going to miss out on those things, right? And that's really painful to think about. When there's a study that was talking about all the different things that people facing a terminal illness fear. And it's not just dying or being dead. There's a lot of other things. There's so much more that's going on. Thinking about fear of being separated from loved ones, being back and forth in the hospital, spending time being sick, fear of becoming a burden on other people, fear of losing control. I am a control freak. Not being in control is something that is horrible for me to have to think about. Fear for dependence, so as I was speaking about my children. Fear of pain or worsening symptoms, I can generally tell you that that's something that we can control pretty well. The fear of dying, just what's it going to look like? I just don't know. The fear of being dead, that's the FOMO. Like, I love life. I don't want to miss out on life. I want to see what the next sequel of some movie that I love is going to be. I think one of the really deep, difficult things is the fear of fears of others. So looking in your friends' and family's eyes and feeling that they look at you differently now because you are nearing the end of your life or you have this illness. And I would argue that that is one of the deepest things that we fear, and that's really tough for us to struggle with, and it can be really isolating. So I think people's usual reaction when they're thinking about this is, I need to stay strong for my family. If I were to get sick, I got to stay strong. I have to stay strong, which means I can't show weakness because I don't want to upset my family and I don't want them to look at me differently or treat me differently. And that means that I have to keep things as normal and as comfortable as possible. I will tell you, unfortunately, that when we're dealing with these situations, it's not comfortable. And there's nothing that's normal for us about this. This isn't normal life. We have a culture of being strong. When we talk about facing illness, it's our battle with a certain illness. And that strength is so important. And so I don't want to underestimate that strength. But I want to look at that a little bit because I think it's just a piece of the puzzle. I think that there's something else that's missing to how we can get through these situations with a little bit of a lighter load to carry. I found this poem when I was researching for this talk, and if you could play along with me, I would ask you to actually close your eyes and think about these words. It takes strength to be firm. It takes strength to stand guard. It takes strength to conquer. It takes strength to be certain. It takes strength to fit in. It takes strength to feel a friend's pain. It takes strength to hide feelings. It takes strength to endure abuse. It takes strength to stand alone. It takes strength to love. It takes strength to survive. When I think about that, I think those are really important things. I think that gives me a lot of inspiration and motivation. One of the things that we do when we focus on that strength is that anything that we do that we think is not us being strong, we feel is being weak. So when I look up weakness in the dictionary, the only thing that weakness is the condition of lacking strength. The weakness in and of itself is not really a thing. Weakness is the absence of strength. And so it's something that I think we confuse, and that we have put this, we've tied this emotion of weakness is bad, and that judgment to it. And so bear with me for just a moment. When I looked up the definition of strength, that is the capacity of an object to withstand great force, pressure, or rough handling. The ability to endure hardship or pain. The emotional or mental qualities necessary in dealing with situations that are distressing or difficult. Strength is important. We need strength. We need strength to get through our day. We confuse fear with weakness, and we confuse vulnerability with weakness. When I am thinking about a time when I could be seriously ill or at the end of my life, I'm going to be afraid. I'm going to be in shock. That's just a natural, normal reaction. That is something that our bodies are going to do without question. Then I have a choice about how I'm going to respond to that emotion. I can avoid that unpleasant sensation and just forget about it and try to move on and pretend that it's not there. Or I need strength to be able to sit with that emotion. I need strength to be able to spend time with that feeling and that unpleasant sensation. If I go into that, then I am acknowledging my vulnerability. I am acknowledging the fact that I am human, that I'm now sick, I'm not healthy like I was before, and that I am mortal, that I'm not going to live forever. And so if I use my strength to get through that situation, to sit in that discomfort and that pain, I need to do something else. I need to reach out to someone else to help me with that. I need support. I need a shoulder to lean on. I need someone to talk through this with me. I need something to help me to get out of this. And oftentimes I will tell you that we need each other. We're humans. We're connected. And so if I'm going to cope with that situation as best as possible, I need the courage to reach out and ask for help. So when I think about weakness and strength, what I really think that we need to be talking about is that strength is what helps us to acknowledge our vulnerabilities and fears. So fear is fear is anxiety concerning the outcome of something or the safety and well-being of someone. Fear is anxiety about the likelihood of something unwelcoming happening. Vulnerability is our ability to be physically or emotionally hurt or attacked. Vulnerability is a fact. We are vulnerable. We are human. We can be hurt. We don't have armor that's on us at all times. We have emotional armor that we carry. And so this is all language that I think we confuse in terms of how we try to get through these situations. So when I think about courage, courage is the ability to do something that frightens someone. Courage is the mental or moral strength to persevere and face danger, fear, or difficulty. So kind of putting this into a little bit more of a visual in terms of what I think happens for us when we're thinking through these situations. Something bad happens. I am emergently critically ill, or I am facing a terminal illness. I'm going to feel fear, sadness, anger, disbelief. I'm going to feel all those feelings, and that's going to happen no matter what. That is normal. And then I'm going to choose how I respond to that. If I only focus on our idea of what it means to be strong, then I'm just in survival mode. And that's important because I need to survive. I need to do that. But if I'm in that survival mode and I'm not staying in that place to acknowledge my fears and my vulnerabilities, then that's going to take up a lot of energy if I'm pretending that those things aren't there. And that's going to be really isolating. If I use that strength that I have to face those fears and those vulnerabilities, and then I use courage to acknowledge to other people that I'm vulnerable and that I'm afraid or I'm stressed or I'm worried, then I don't have to do this by myself anymore. I have someone who can do that with me. And so I have the support of others. And I will tell you that when I see that light click on for people, it is so powerful. And I can see the weight lifting off of people's shoulders as their families are able to discuss these things out in the open. So I want to go back to that poem, and I want to add courage in the picture. So again, if I could have you, I'd like you to close your eyes and think about the nuance in the similarities and how courage can add to this. It takes strength to be firm. It takes courage to be gentle. It takes strength to stand guard. It takes courage to let down your guard. It takes strength to conquer. It takes courage to surrender. It takes strength to be certain. It takes courage to have doubt. It takes strength to fit in. It takes courage to stand out. It takes strength to feel a friend's pain. It takes courage to feel your own pain. It takes strength to hide feelings. It takes courage to show them. It takes strength to endure abuse. It takes courage to stop it. It takes strength to stand alone. It takes courage to lean on another. It takes strength to love. It takes courage to be loved. It takes strength to survive. It takes courage to live. So a couple more quotes that I think highlight what's going on in our heads as we're facing these situations. That fear is a reaction. Fear is something that is hardwired in us. Courage is a decision that we make. Courage is how we choose to get through this. Brene Brown has been a tremendous support through me going through COVID. It's free therapy if you listen to her podcast. She has this wonderful quote: "You can choose courage or you can choose comfort. You cannot choose both." These conversations are uncomfortable. They are uncomfortable because they are hard and they are important, and it gets to the core of what it means to be human. And if you choose to be courageous, these can be incredibly powerful, wonderful, connecting conversations. So kind of getting back into these advanced care planning and how this relates to healthcare. When I see patients and families as they are facing issues around healthcare decisions at the end of life, what I see the struggle is this question of, I want to know that I did everything I possibly could against this illness. I don't want to let my family down. I don't want my family to see me as weak. I don't want to depend on anyone. I want people to continue to see me as strong and unbreakable. I will tell you, we are all strong. Everybody to get through their day is tremendously strong. We are all balancing amazing things every day. None of us are weak. This is kind of this false narrative. None of us are weak. We are all incredibly strong. The question is if we can have courage to go beyond that strength and have courage. One of the things that is really important for people to think about as they are facing healthcare issues is, what do I have control over and what do I not have control over? What does my doctor have control over and what do they not have control over? As much as I wish, with all of the amazing advances that we had in modern medicine, we know that there are limits to what medicine can do. We know that people do not live forever. And so at some point, all of the different healthcare interventions that we are able to do are not going to work like we hoped they had. And then I think another important piece to this, and this is really sensitive and difficult, is, do you trust your doctors to be honest with you and your family if the treatments aren't helping like you hope they will? You need someone that you can trust on your healthcare team. Whether it's the case manager or your social worker or whoever it is, you need someone that can go to bat for you, that if you're not sure how things are going and you're not sure if people are being honest with you, You need someone that when you're ready to ask that question and ready to hear the answer, that you've got someone who can help you with finding those answers. So I'm going to give you a little bit of an insider view about how healthcare professionals think about issues when taking care of patients in general and taking care of patients when they're facing serious illness. I will tell you that these are my personal opinions, but I have had enough conversations with enough good friends that I think are very wonderful doctors that I think they would, generally speaking, agree with what I'm going to show you. When I think about kind of the three biggest categories of what makes me afraid, when I go into an exam room and I can actually feel that I'm anxious, that I'm worried and I'm frightened. I don't want to upset my patients. I hate upsetting my patients. So kind of a somewhat lighter example is if I'm talking about losing weight with a patient. So this is something that I don't want my patient to think that I am coming from a place of judgment or that that there's any sort of judgment is the best word that I'll use. I care deeply about my patients and I respect all of my patients and I want them to be as healthy as they can be. And if I am going to be the best doctor that I can, I need them to have the best information and the best resources for them to be as healthy as possible. And so if I have a person who's really overweight, we know that that contributes to a lot of health conditions as they continue to get older. And so it's important for me to have those conversations. I'm actually being a bad doctor to my patient if I don't bring up that uncomfortable conversation. And I need to do it in a compassionate and respectful way. Another piece to this is when I'm giving bad news. And that bad news doesn't need to be something that's life or death. When I have patients who have bad arthritis and I say, gosh, I wish I had something different. I think this is kind of the pain that you're stuck with in your hands for the rest of your life. That sucks. I hate saying that to people. Failing our patients. There are times when I have failed my patients. I was supposed to make a call and I didn't. I was supposed to put in an order and I didn't. And so there was a delay in care. And that's something that it's the reality of the day, what happens. I'm human and I'm vulnerable too. And of course, I hate when I do that. I know there are times when I have walked out of an exam room and a patient has had questions and concerns and I know it didn't click. I know that they had questions that they were asking and I was trying to give the best answers that I could and it did not fit. And I hate it. I hate when that happens. And then there's the really serious stuff. And this is the stuff that makes healthcare providers incredibly distressed. And that's when we harm our patients. When we make medical errors, there's never the intention to harm people. So all doctors take an oath. The first oath that we take is do no harm. And so when we make mistakes, it's an awful feeling. And especially, I will tell you, when we provide medical care that we know isn't likely to help when we wish it could. So right now, as I'm giving this talk, we're in the time of COVID. So we are trying to save every life that we can. And there are some people who are on breathing machines that is, as best as we can tell, as certain as we can be, those breathing machines are not going to get them back to the place that they were before they had this illness. And most of the time, we're able to have honest and open discussions with patients and their families about that. But there are some times when, for various different reasons, those patients stay on those breathing machines. And again, we just know that it's not going to help and it's not going to get them back to where we wish they could be. And that's really distressing. And it's this really fine line where something that was this hugely important life-saving technology has now become something that I will tell you honestly feels like it's torturing patients if we know it's not going to help. When we as healthcare providers have discussions about thinking about issues around the end of life, whether it's in advanced care planning when someone is well or when someone is really sick, it fits all of these buckets. So it's upsetting and it's uncomfortable to talk about. It feels like a failure of the medical system. We feel like we should be able to make people live forever, and unfortunately that's not the case. And it feels harmful. This brings up strong emotions, and that's normal that it brings up the strong emotions, but we're just not prepared with how to deal with those emotions that come up. In terms of kind of translating this back to medical care and how we as healthcare providers try to bring this up with patients and families, I will be perfectly honest with you, healthcare providers are not well trained how to have these conversations. We're working on it. It's something that is very important in terms of how we educate and train our future healthcare providers. And at the same time, we're just not where we need to be in terms of being open and honest and respectful and compassionate and having these conversations. I will tell you that the closest that we get to this in general is when we bring up something that's called code status. Oftentimes, this is something that is done when a person is admitted to the hospital, and we will say something along the lines of, hey, by the way, just in case, something that we ask all of our patients when they come into the hospital is, if you were to get so sick that you were at the point where your heart stopped beating or your lungs stopped working, would you be okay with us restarting your heart and putting you on a breathing machine or doing everything we can to save you? And as I listen to myself say these words, I say, sure, yeah, flip the switch. That sounds great. Like, yeah, of course. And at the same time, what I will tell you is that what we see on TV, where we see Dr. McDreamy somehow doing CPR on his girlfriend, which is weird, but it looks like this calm event that the doctor's got it under control and the person's just going to bounce right back to how they were before. In reality, what we know is that when we do these things like CPR, it's hectic, it's chaotic, it's stressful. And unfortunately, it doesn't give those outcomes that we see on TV. It doesn't work as well as we could. Generally speaking, about 10% of people will be able to leave the hospital and get back to the life that they had before that illness. And so in terms of thinking about this, we've got healthcare providers that are hyper-focused on having the conversation that way because that is what they fear the most, is they don't want to perform CPR on a person who's not going to benefit from it. And at the same time, we are trying to distill this incredibly complicated situation down to that one question, or do you have an advanced directive, and then moving on from there. So in terms of how I would ask you to think about these issues that I've been bringing up, I would ask you to start asking yourself some tough questions. What is most important to me if my health gets worse? What are my biggest fears and worries about the future of my health? What abilities are so critical to my life that I can't imagine living without them? If I become sicker, how much am I willing to go through for the chance of more time? How much does my family know about my priorities and wishes? How am I going to start talking about this with my loved ones? Do I trust my healthcare team to be honest about how my health is doing and if I need to be planning differently for the future? I think about advanced care planning as kind of a stages of change. So this is a model that I think about for people who are quitting smoking or people who are wanting to lose weight, that we cycle through kind of these 5 main areas and we go back and forth between them. So by listening to this, you have been forced to be in pre-contemplation. And again, I thank you for your attention with this topic. I'm hoping that some of you, this is resonating with you of, hey, this makes sense. And this is stuff that I really need to start thinking about. Some of you may be in a place where you're like, you know what, by the end of next week or by the end of next month or by the end of this year, I'm going to talk about this with my family. And some of you may be actually in action phase where you say, next week, I'm going to go get my advanced directive. I'm going to ask my primary care provider at my next visit about making sure that I have this form and that they know my wishes. I am personally in the maintenance phase. So I first did an advanced directive when I was giving a talk similar to this a couple years ago, and I felt like a hypocrite for giving a talk on this and not having an advanced directive. And that is something that at the time, my husband and I were thinking about having more kids. So in my advanced directive, I actually address what to do if I'm critically ill and I'm pregnant. Now we've had our kids, we're done having kids. And so I actually need to go back and update that advanced directive. It doesn't make sense for me if I leave this in place to be 57 and the doctors are saying, why does this woman have this pregnancy language on her advanced directive? So that's something that's actually updated over time. In terms of getting back to those nuts and bolts about what is the advanced directive and how would I complete it, there's 2 parts to an advanced directive. You can complete either part, or you can complete both of them, or not at all. So that medical power of attorney portion, that is who speaks for you if you're too sick to speak for yourself. As best as I can, I'm really careful about using that language of who speaks for you. Or when I ask them, I would say, what would your parent or what would your husband or your wife or what would your loved one say if they were hearing what I was saying right now? Not what would they want, not wishful thinking. What would they say in response to what we're saying right now? Make sure that your power of attorney knows that they are your power of attorney, and make sure they know your general wishes. Because I do this work, my husband loves to joke with me that he will keep me on a ventilator forever and ever and ever if I am in one of those situations. So when I sat down to do my advance directive, I actually had to have the discussion with him of, are you going to honor what I have in this document? And are you going to make sure that if things aren't working, that you actually stop those things and let me die naturally? And he acquiesced. So he is my primary power of attorney. But I told him, if I can't trust you, I'm going to have my sister be my power of attorney. And she's my secondary power of attorney. And then in that living will, so of course I love my husband and I still don't totally trust him. So I'm actually kind of more specific in my living will language about my wishes so that healthcare team has that backup that if my husband is freaking out and he's panicked and he doesn't know what to do and he's not able to help with those decisions, that I'm actually giving pretty clear guidance as best as I can about what I would want in that position. So the living will is stating what are the medical interventions that I would want as part of my care? What are medical interventions that I would want to avoid as part of my care, depending on what is coming up? Some practical things are thinking about where you're going to keep that document. Most people who have advance directives say, I have it somewhere, and they don't know where it is. I have it in a folder that's in my desk in my house, and then I also have a copy that's a PDF that's in my email, and my husband and my sister have that in their emails. And then thinking about who else needs a copy. So I will actually admit my primary care physician does not have my advance directive. So again, that's one of those maintenance things that I need to make sure that I get that to them. I mentioned this briefly. For most of us, this is not a once and done kind of document. This is something that gets updated over time. So once I get my pregnancy language out of my advance directive, it's probably good for me until I'm in my 60s or 70s, unless I'm diagnosed with some kind of health condition where I say, you know what, it maybe doesn't make sense for me to try all the different scopes of medical care if I were to get a lot sicker than this. For anyone who I think about kind of like big reminders about revisiting this conversation, if you're moving into a different type of living situation, if it's difficult for you to maintain the home that you've had, that's a sign that you're not moving around like you used to, and it probably makes sense to revisit if all the scope of medical interventions that we might do would make sense for your care. Any new diagnosis that a doctor says will be with you for the rest of your life and doesn't have a cure, it's worth thinking through those things. Again, do some of those medical interventions maybe not make so much sense for me? Two practical resources that I would recommend are, one is the Conversation Project. So this is a website. They have a really helpful, wonderful, it's about 12 pages that you can print out. And it's pretty straightforward questions, but really helps to stimulate that conversation. I would personally recommend, if you have a power of attorney, sit down with that. And you don't have to write it down, but just look at those questions and just kind of talk through it with that person. The other resource that I think is really helpful is called Prepare for Your Care. It has videos, and so I think it brings up common issues and common questions that people have. And I think it, again, just normalizes that these are all thoughts and questions that we have. The videos are a little bit hokey, but I do find this to be a really helpful website. In terms of those steps of actually completing that advance directive, this is something that your primary care provider should have access to these forms. You can do this through your attorney. Your attorney is really important for doing that financial power of attorney. I would tell you that technically speaking, they'll charge you for that. So you can do this for free through your primary care physician or on your own. Again, it would require a notary that you should be able to get through your bank, or two witnesses that are not your family, not your power of attorney, and not your healthcare team. There's specific forms that the easiest ones in my mind that are most apparent are, there's a Nebraska, state of Nebraska advance directive that you can Google online. There's also a 5 wishes form. I do think that there's a fee that's associated with purchasing that. I will tell you there are hundreds, if not thousands, of different forms of advanced directives that are out there. I want to touch base briefly on something that I consider to be a very narrow part of advanced care planning. And this is for people who may have heard this conversation and they say, under no circumstances would I want CPR or breathing machines to be a part of my medical care unless it was, a breathing machine for a brief planned surgery. If that is your value and preference, then that is something that I would direct you toward a different type of form. And these are effectively out-of-hospital DNR, DNI forms. Do not attempt resuscitation, do not intubate. So that is referred to as a POLST form, or provider orders for life-sustaining treatment. In Nebraska, we have a specific form that's called the Nebraska Emergency Treatment Orders, or the NETO form. In Iowa, we have the IPOST form, the Iowa Physician Orders for Scope of Treatment. That's a medical order that would be signed by a physician that if by chance you have an awful heart attack at home, the emergency medical services would come to your house. If you're talking to them and you're saying, I'm in bad chest pain, they're going to take you to the hospital. They are going to do everything that they can to make you more comfortable. They're going to take you to the cardiac cath lab and do that procedure for you. But if you have such a bad heart attack that you go into cardiac arrest and you effectively die, then in this situation, they would not try CPR to bring you back and use breathing machines for that recovery. So if those are your preferences, then that would be a form that I would direct you to. And that is something that doesn't make sense for a lot of people when we're healthy, but that is something that can be really important for your healthcare team to know if you're already facing a lot of different medical conditions, and it would be a lot to go through something like that. This slide is just to show you some comparisons between that advanced directive and that POLST form. I see the advanced directive as something that everyone should have. It is something that, again, if you walk out on the street and you get hit by a bus and you're in the ICU, that you need some guide for your family about how to provide the best care that we can for you. And then that POLST form is really getting to people who I would say either have a very clear preference against those types of medical interventions, or maybe it just doesn't make as much sense for us to do those because we know that it won't work like we hope it would. So first and foremost, again, I want to thank you so much for your attention and engagement with this talk. My last plea to you all is just allow yourself to feel the feelings that come up with this. Allow yourself to feel fear, to feel worried, to feel anxious, to feel dread with thinking through some of these issues. Allow yourself to be vulnerable, because we are. Allow yourself to use your strength to find courage by talking about the medical care that you want at each stage of life. And so I'll finish with another quote, and I love this, from Oprah. The thing you fear most has no power. Your fear of it is what has the power. Facing the truth really will set you free. So thank you again.
Remember when we were little?
Mm-hmm.
Whenever I needed you, poof, you appeared.
Like magic?
Yeah. When I had cancer, same thing.
What do you mean?
Well, Nebraska medicine was amazing. Treating my cancer based on my own DNA.
Pretty amazing.
But you did the magic part.
Like what?
Exactly what you're doing now.
For Nebraska's only NCI-designated cancer center, begin with Nebraska Medicine.